Thank you very much, Mara. Next, it is my pleasure to introduce Dr. Marina Pieri, who is coming from the hosting institution in Milan, from the San Raffaele Institute. I'm very looking forward to her talk based on this first poll, because she will introduce us in different pathways of care for patients with acute cardiogenic shock, with a focus on myocardial recovery, which is a quite important group we encounter every day. So Marina, the floor is yours.
Okay. Good afternoon, everybody. I'm Marina Pieri from San Raffaele Hospital in Milan. As briefly introduced, cardiogenic shock is a very complex clinical scenario, and it is my pleasure to speak about current trends and data concerning treatment. In this presentation, we will go through three main chapters: how strategies of support have evolved in over years, which are the current possible pathways of care for these patients, and finally, we will present and discuss the concept of native heart recovery. So there is no need to say that temporary mechanical circulatory support plays a major role in the treatment of patients with cardiogenic shock. In particular, veno-arterial extracorporeal oxygenation offers the possibility of powerful circulatory support, immediate hemodynamic stabilization, and it facilitates end organ recovery. Although available for over 40 years, it is only in the last 2 decades that it has become the widely used, or I would say even the preferred device for temporary mechanical circulatory support in patients with cardiogenic shock. We all agree that VA ECMO represents a life-saving technique in selected patients, and currently it is recommended in refractory cardiogenic shock cases. Although some important studies, even randomized studies, are still on the way and will provide additional relevant data. It is also clear that survival is influenced by patient condition at presentations and the cause of shock itself. So treatment should be always timing. This study from Alain Combs, a study from France, provided very interesting data showing that ECMO 1-year survivors present better health quality of life and better clinical outcomes compared many patients with chronic diseases. You see, patients, 1-year ECMO survivors are patients with the black bullet point, so the second line from above. The first line shows the normal controls, health quality of life. Of course, this is the better performance. But ECMO 1-year survivors present better outcomes as compared to patients with chronic hemodialysis, on the compensated heart failure patients, and even 1-year survivors of acute respiratory distress syndrome. So these are very encouraging results that support the use of VA ECMO in patients on cardiogenic shock. So here comes the concept of the pathway. Temporary mechanical circulatory support and VA ECMO in particular is a bridging strategy. And namely, it is a bridge to myocardial recovery, if possible, or a bridge to further therapy, that is to say, durable LVAD implantation or heart transplantations. But what happened in these cases? Especially in European countries where organ donor availability is limited, durable LVAD implantation is a frequent destiny in patients with poor ventricular function. And this multicenter study, focusing on VA ACLS as bridge to durable LVAD implantations, showed that in patients who arrive at LVAD implantation on VA ECMO support, 1-year survival is 53%. So it is a feasible strategy, very important, but this is also the lowest survival rates reported after any form of contemporary durable support. So patients should be carefully stratified. This is also the conclusion of this study, and they should be carefully selected for this type of pathway. Similarly, VA ECMO is a viable option as bridge to transplant. Again, however, survival in patients transplanted on VA ECMO is slightly inferior, so a 7% increase mortality rate compared to non-MCS patients. This risk is, however, acceptable if you weight it against the risk of death on the waiting list for heart transplantations. These are official Italian data from the National Transplant Center from 2021, and there are a couple of these data that should be stressed. First, it has been reported an increasing mortality rate in the waiting list. In 2009, it was 6.9%, increasing compared to previous years. Second, the time on the waiting list for adult patients with cardiogenic shock is not less than 15 days, even in the urgency list. And last, half of the patients transplanted in 2029 were below 60 years of age. So definitely heart transplantation is not for all cardiogenic shock patients.